Hello everyone, welcome to our MRCOG 3 Made Easy. Today we are going to talk about the important topic, that is which you need to know about the sterilization. Sterilization means a patient who comes for requesting sterilization. So then you need to counsel her depending upon the situation. So here this case scenario is like this. Again, it is a structured discussion. It is case-based discussion, structured discussion with the examiner. He will be asking you a few questions, so you have to answer whatever he asks. You have to answer. So you need to know about the method, all the options where you can contraceptive options which you need to know. So that is an important topic. Now here your consultant will conduct a case-based discussion with you on a patient requesting sterilization to assess your ability to manage a similar patient. Here she is a here she is a 29-year-old in new relationship for 6 months, insisting on sterilization. She is para 1. Her first delivery was by cesarean section, and second was an ectopic, which was managed laparoscopically. At laparoscopy, they were dense adhesions. She is a smoker and smokes cigarettes, that's 10 cigarettes a day, or then non-epileptic. So, from this scenario, you know what are the factors, risk factors, and why you need to advise her against sterilization, because she is insisting. So, look at the age. And the same, and she's para 1, that's why she wanted sterilization. She is a 29-year-old, young, less than 30, and she is in a new relationship. She's a risk factor, smoker, and epileptic. So now, examiner will ask you few questions. So he can, these are the few questions which we displayed, but questions can be any type. So you should be thorough with this topic. Now, coming to the, so you have to introduce yourself. Hello, I'm Angela, one of the part 3 candidates today. I have read the instructions and I'm ready for the case-based discussion. So then he will say, what do you think the sterilization is right option for her? Then you say, thank you for your question. So she is, in my opinion, she is a young patient, 29 years, that is less than 30 years. That apart from that, she is in a new relationship. So the possibility of having a future pregnancy, and she may change her mind and may look for further pregnancies. So that's the second thing. Third thing, sterilization is a permanent method. And though permanent method, there is a risk of failure 1 in 200. So now she has also she had a cesarean section and also laparoscopy which was showing dense adhesives. She has associated surgical challenges because of the previous one cesarean section and post-operative adhesions. And so high probability that this laparoscopy may fail and conversion to laparotomy. And also the risks of the associated with the laparoscopy or laparotomy, the risk associated. It could be organ damage, that is injury to bowel, bladder, and ureter, and also blood vessels. They can be intraoperative injuries, and also there can be other surgical risks like pain, bleeding, infection, and a risk of ectopic pregnancy in future. So these are the things which are called surgical complications, and they can be associated anesthesia issues also, because she's a smoker and she's an epileptic. So in view of this her engage, and in view of her comorbidities, and that is the previous cesarean, previous surgeries with adhesions and associated anesthesia challenges, I don't think that I would give sterilization a good choice for her. Now, how would you counsel? Then he will ask you, how would you counsel her? Yeah, you say, first of all, for counseling, I need to know to explain to her the risks sensitive. I would need to talk to her very sensitively. Why she wants sterilization? What's the reason for sterilization? We need to know the background, because no one will opt for sterilization when she is in relationship. So we need to that you're not telling the examiner. I'm telling you. So we need to know why she wants. So the reason, I would like to ask her sensitively the reason why she wants sterilization. Are there any mental health issues, any domestic violence? I would like to rule out any social pressure from the family, and what kind of situation she's forcing her to take this decision. I'd also ask her. So this way we have to ask sensitively, because these are the sensitive things. Then I would also ask her about the knowledge, whether she knows anything about the sterilization. So explain to her about the sterilization. I'll give her a detailed information about the sterilization. I'll draw a diagram and show her how it is done and the risks and benefits because of this surgery, and also surgery and also anesthesia complications, and also her associated comorbidity, that is epilepsy. She's epileptic. And also I will tell her it's not the 100% success rate is not there. There is an amount of failure rate. So these are the things I would like to explain to her about the sterilization. Then I will also give her information about other contraceptive methods that are available with because and with the, I will explain to her other contraceptive methods with the risk and benefits. And then she can after that I will ask her to go through the, I'll give an information leaflet, written information leaflet about all the methods, and I will ask her to go through. And then if I will ask her whether it's now that options are given to her, the contraceptive choice of her choice can be, we will respect her choice. After going through, if she takes a decision, we will respect her choice. Then if she opts for the contraceptive methods, we will refer her to the contraception clinic. Now, the other question, now you wait for some time. So the examiner will ask you, what are the other methods of contraception? Can you explain? And with their failure rates, then you say, before discussing other methods of contraception, I would like to gather some information from her to assess the suitability of the contraception, the contraception to her. So I will take details of the LMP. LMP, I will see whether when was menstrual period, and whether any previous contraception if it is delayed, if the LMP is delayed, I would like to ask her for a pregnancy test. And then I will ask her whether she has used any contraception before, whether she is up to date with the cervical screen. I would like to check her. And also I would like to ask her whether she had any sexually shared infections, sexually transmitted infections. If so, if she says yes, I would like to ask her whether she had been treated and her partner has been treated. I will also ask her the coming to the medical problems. I will ask her the associated medical comorbidities, whether she has any diabetes, whether she has any hypertension, any migraine, any headache, whether she has any asthma or any liver disorders, and any any breast cancer, whether she has any breast cancer or any cancers. We want to rule out the cancers, or any thrombotic episodes, and whether she is allergic to copper. So, and because these are the things, and whether she has any medical problem, other medical problem like epilepsy. So these are the things which are important, because if we want to advise the contraception, the hormonal contraception, we need to rule out these contraindications. So then I'll check her BMI also. Then these are the options, all the options I will discuss with her, and I will give the choice to her. Now the first option I would like to discuss will be that is a levonorgestrel intrauterine system. That is, I will explain to her with a diagram. I'll tell her that it is 99%. The effect it is effective, and it is not affected by the carbamazepine which she is taking. There can be failure rate. There can be, I'll explain to her the failure rate, that is less than 1 in 100 pregnancies can happen in a year, and once it is inserted, it can be retained for 5 years. So then I will tell her about the action, its action. I will tell her that it prevents the fertilization and implantation. And about this is the action, and then I will explain to her about the benefits. That is no delay. There is no delay in return of fertility. There is no weight gain, and it is a good no effect on the bone density. It's a good option for menorrhagia. It's a then it can protect, but there is no protection from the sexually transmitted infections. So this way I will tell her about the benefits, and I will explain the side effects also. That is the risks. That is, there can be irregular bleeding, initially common in first 6 months after the insertion, and it is followed by the amenorrhea by the end of the first year of the insertion. And there is a small change in the mood because of the progesterones, and also there can be a small change in the mood, and also reduced libido, and there can be acne. And during the insertion, with the insertion, there can be perforation, which can be 1 in 1,000. If we can remember, we can tell 1 in 1,000. There can be chance of infection from the procedure, that is 1 in 100. Expulsion, there can be expulsion also, that's 1 in 20, and ectopic pregnancy, the chance of ectopic pregnancy also is there. So these are the things I would like to explain to her. Then that is the risk and benefits. Then I would like to tell her the contraindications for this. So that is migraine, any history, if there is any history of thrombosis, venous thromboembolism, it is a contraindication. And so these are the contraindications, any cancers and these things which I will explain to her. Then it can be, so it can retain for 5 years. Now the other method, moving on to the second method, that is a copper triton contraceptive device. I will explain to her about the second method. So this is a non-hormonal method. I will tell her that it is 99% effective. It is not affected by the carbamazepine, that's anti-epileptic drug, and it can be used for 5 to 10 years. And I will also explain to her that there is an MO, even in spite of this method, there is a chance of failure rate that is less than 1 in 100 pregnancies. There can be pregnancy in spite of contraceptive device. And then action, coming to the explain to the action, it will prevent the fertilization and implantation, and it can have some side effects, like it can cause some heavier periods or some pain during the dysmenorrhea. And during the complications, there can be some complications with this device, that is perforation during procedure, infection, expulsion, and ectopic pregnancy. So these are the things which I will explain to her about the risk and benefits. And for both the intrauterine contraceptive devices, both, that is levonorgestrel intrauterine system and copper intrauterine device, the prerequisites are, before insertion, we need to screen for the infections like sexually transmitted infection like chlamydia, gonorrhea. We have, and so we have to rule out the pelvic infection, and so we try to do the screening. If the screening is not positive, if that possible, then we will give prophylactic antibiotics before the insertion. Then because these they are not in women who are at risk of sexually transmitted infection, like we give the azithromycin 1 gram single dose or doxycycline 2 times a day for 7 days. It can be used. These devices can be used in all ages, during breastfeeding, in adolescents, in nulliparous, and also in HIV positive, and also in medical disorders like diabetes and epilepsy on enzyme-inducing drugs. So we can use these methods in all these conditions. And time of insertion, it is ideal during periods, first 5 days, and without any additional contraception. But if it is inserted after 5 days of the period, we need to give her additional contraceptive for 7 days of insertion. So the time of insertion, I told you, it will be during periods. Then always when we have to exclude pregnancy. So LMP is an important thing which we know to know, and also during menstruation we can insert. And then if it is after 5 days, additional contraception. Second thing, immediately after first trimester and second trimester, abortions. We can insert this. Postpartum, if it is she delivered, and then within less than 48 hours we need to insert, or after 28 days after delivery. Then we will advise her to continue her anti-epileptic drugs during insertion, because when we do the insertion, the cervical dilatation causes seizures. So we have to advise that she need to continue the medication. We should not stop it. Then follow up after the insertion. We have to ask her to come after the first period to check for the threads. So then afterwards, we will explain to her. She can do her self examination. She can check for threads. Whenever she doesn't feel the threads, she need to report to the healthcare professionals. So then third option. So now moving on to the other method, that is the third option, that is injectables. These are the progesterone injectables, that is dipomedroxyprogesterone acetate or non-episteroid enantate. So these are 99% effective. With a slight failure rate is there, that is less than 1 in 100 pregnancies in a year is there. So it is not 100% foolproof. There can be a failure rate also, but small failure rate. It is not affected by the anti-epileptic drugs, that's the carbamazepine. That's one more advantage. And the action is it prevents ovulation. So that is the action. And so the pregnancy rate also, the advantage is very low pregnancy rates. That is very low failure rate. Then it can be taken every 12 weeks or every 8 weeks. And so the advantages, it is not associated with the so headache, acne, and depression. And the disadvantages are irregular bleeding. They can be irregular bleeding, delay in fertility, and it does not, and bone density. So the bone density is affected, and then it will not prevent the sexually transmitted infections. And so it cannot be, so because the bone density is affected, it cannot be used for longer time in young women. And also there is a small weight gain by 2 to 3 kg in a year. So because it cannot, if it is not going to prevent the sexually transmitted infection, we need to advise safe sex practices. That is using barrier methods along with this. We need to encourage that. And because she is on carbamazepine, that is an enzyme inducer, so this is safe. But other progesterone methods, that is, then progesterone only pills, the implant, progesterone implant, and combined contraceptive pills, they are not suitable because she is on enzyme inducing drug. So now, time of insertion, time of injection, taking the injection, up to 5 days of the menstrual period, she can take without any additional contraception. But if it is after 5th day, we need to give her additional contraception for 5 days, for 7 days. Then she can also start it after first or second trimester abortions, postpartum period also she can take. And if it is dipomedroxyprogesterone acetate, which is taken for 12 weeks, every 12 weeks, we can give up to 14 weeks. That is 2 weeks late also we can allow. But after that, we need to give additional contraception if she comes much later than that. And studies show that it does not cause any congenital malformations if pregnancy occurs. So, and we need to at the same time, so these are the methods we will explain to her, the reversible, the long-acting reversible contraceptive methods. We will give the options, and then along with the risk and benefits. At the same time, we need to tell a word about the vasectomy also. But here, she is, in this case, vasectomy is not a suitable choice because she is in new relationship. So this is the information which I would like to give her, and then I'll give her the options, and I will ask her to decide, then get back to us. So give a follow-up appointment in the contraception clinic so that further treatment can be started for her after she takes a decision. So this way I will counsel her, this young lady who insists on sterilization. Thank you for your time.